Hello again. In the previous lecture about periodontal abscess, we reached to the point when the new classification of periodontology classified or categorized the periodontal abscess in two ways. One of them is periodontal abscess in periodontitis patient and the other one in non-periodontitis patient. We finished that and we discussed that. Today we are going to discuss the rest that's related to periodontal abscess, starting from microbiology of periodontal abscess. Many gram-negative bacteria are present inside the periodontal abscess. One of them is Porphyromonas gingivalis, Prevotella intermedia, Fusobacterium nucleatum, and Actinobacillus, Actinomycetum comitans, Campylobacter bacteria, and Prevotella melaninogenica. These types of bacteria are all of them virulent bacteria and gram-negative that are present in periodontal abscess in different proportion. How we investigate the periodontal abscess? One of the ways are through radiograph. We take, for example, periapical radiograph, and to know the exact position of the periodontal abscess, we may use Guttapercha point through either the sinus tract of the abscess or throughout the pocket to know the exact point or the exact location of the periodontal abscess, because sometimes you find a swelling in an area and when you examine it through radiograph you find that the exact position of the abscess is not what happened or what you see it clinically. It's in a different position or have a different source. So we take a periapical bite wing. Also we take a bite wing x-ray to assess the marginal bone loss, and also an OPG to get an overall view of the condition. The second way of investigation is pulp vitality test. In the periodontal abscess, the teeth are vital. We talked about that. So we must have vitality when we are examining the periodontal abscess, except in cases of combined lesions and perioendo lesions. In these cases, we may have some feeling of pain while during examination. For example, when we do a percussion test, or some case of some other tests to assess the vitality of the pulp. In the microbial test, pus samples from sinus or abscess could be sent for microbial culture and antimicrobial sensitivity test. This is another way of investigation. Another way is lab finding. We may find during the blood test that there's a lot of leukocytes, neutrophils, monocytes, and these all suggestive of either an acute or chronic inflammatory response of body to bacterial toxin in the periodontal abscess. We have other investigation like assessment of diabetic status. We said that diabetic patients are more prone for undergoing through the acute periodontal abscess. They have a defective immune mechanism and a defect in the innate immunity, which are the first line of defense against any bacterial invasion. So the other investigators including diabetic status of the patient. Going through differentiation, how to differentiate different type of condition that are similar to periodontal abscess. For example, in the gingival abscess, the abscess is confined to gingival margin and interdental papilla without the presence of periodontal pocket. While in case of periodontal periapical abscess or pulpal abscess, here the abscess is located in the root apex, not in the pocket or on the lateral surface of the root, and the tooth is non-vital, opposite to the periodontal one, which is vital. And most of the time you see that these teeth have a heavy filling or large filling, and a large caries or pulpal involvement, and there is no sign and symptoms of periodontal disease. Well, in case of periodental lesion, actually this is a tricky situation we may talk about in a separate lecture, but here the tooth are mostly non-vital. The tooth are sound or minimally restored and have severe periodontal disease, or sometimes furcation involvement close to the apex, causing pulpal infection. In cracked tooth syndrome, also we have a vital tooth and history of pain on mastication and pain upon releasing on, for example, a rubbery or cotton roll, and there is no relief of pain after endodontic treatment. We have root fracture. Also in this case, you have non-vital tooth with heavily restored and mobile tooth with localized deep pocketing, normally in one side, which may need a flap exploration to confirm the diagnosis. So this is related to the differential diagnosis. Related to treatment, we have immediate management, initial management, and instructions. If we have an acute abscess and the condition is life-threatening, so systemic antibiotics, supportive therapy, and when necessary, consulting an expert. Also, reassessment is necessary for both chronic and acute one. And we reach to a definitive therapy treatment. When we give an antibiotic, when we do a drainage, then we see the patient each and while to confirm the definitive treatment. So this is the way how we treat an abscess. In life-threatening infection, hospitalization, supportive therapy, together with antimicrobial therapy will be necessary. But in non-life-threatening condition, systemic measures such as oral analgesics and antimicrobial drugs will be sufficient to eliminate systemic symptoms, severe trismus, or diffuse spreading infection. So sometimes we need an urgent treatment, and sometimes the supportive therapy with the antimicrobial will be enough. Of course, beside the drainage, will be enough for the treatment of periodontal abscess. The common antibiotics used are phenoxymethylpenicillin, amoxicillin, metronidazole, and if there's an allergy to penicillin, there's erythromycin, doxycycline, clindamycin. We are here in Kurdistan mostly using metronidazole and amoxicillin, which are the best combination for treating a periodontal disease. And especially for abscess, we are giving it for 5 days, 400 milligrams twice daily. But the amoxicillin, we give it 3 times daily till we find an improvement of the abscess. Irrigation of the abscessed pocket with saline or antiseptic, and when there is any foreign body, it should be removed. Drainage through the sulcus with a probe or light scaling of the tooth surface. Compression and debridement of soft tissue wall or curettage, and oral hygiene instruction. And the instruction should be not to rinse till 24 hours, and after 24 hours, the patient should do a mouthwash, warm water with chlorhexidine every 2 hours. Then the area should be cleaned by soft brush and water. The patient is asked to return in 1 week. And after 1 week, the pack is removed and the patient is instructed about the plaque control. And the gingiva appear normal within 6 to 8 weeks, while bone repair takes 6 to 9 months. And this is the end of talking about periodontal abscess. I hope that I covered the most information that related to periodontal abscess. Thank you for joining, and have a nice day.